I'm Nick. Quite a few of you have met me before. I work in advocacy for leukemia care, and I'm healthcare liaison officer. And I'm also a chronic lymphocytic leukemia patient. So hopefully during the discussion, I can also add in some inputs that are relevant to the CLL group. And Helen is obviously going to give a presentation that's going to cover, as where possible, across all of the different leukemias. So perhaps I can start with introductions. Angela, would you like to introduce yourself? You're muted, Angela.
Hello, I'm Angela Watts. I work as a haematology nurse. I work in research as well, and I'm also a nurse advisor with Leukemia Care.
Thank you, Angela. Helen?
Yeah, hi everyone. I'm a senior research fellow at the University of Birmingham and an honorary consultant haematologist at the University Hospitals Birmingham.
Sam?
Hello, I'm Sam, and I was diagnosed with AML in April 2016, and I've had a stem cell transplant.
Julie?
Hello, I'm Julie. I was diagnosed with APL in February 2017, and I'm currently in clinical remission.
And David?
I'm David Fitzgerald, and I'm a CML patient of about 10 years and a patient advocate as well.
Well, thank you all of you for joining us, and I can see that we've got quite an audience and we've got a lot of ground to cover, and it's a very unsettling time for the community at the moment. So hopefully amongst us as a group, with the audience and the questions, we can help each other as we transition to next stages. Whilst I'm looking at things, I think it's clear that there is going to be a transition, and changes and ends to lockdown are going to happen in different rates and different ways across the different nations. So obviously the England announcement is happening a bit more detail this afternoon, where changes are due on the 19th. We can't talk about the exact nature of the changes because we're not clear of them, but I think the press have been given us a good indication. We're expecting many of the COVID rules to become voluntary, such as masks and social distancing, but obviously we need some clarity on that. And there is some advice that should be coming forward today for the clinically extremely vulnerable. Let's hope so. Yeah. Scotland have moved to level 0 on July 19th. There's going to be some additional restrictions, limits on how many people can meet, etc., which is no bad thing. And all restrictions are due then to lift on August the 9th. So they're in a little bit of a different place. Wales have already confirmed that they're going to keep masks on public transport and in hospitals, etc., and in shops. To be confirmed. Yeah. The full announcement for Wales is Wednesday on when all restrictions will lift. And Northern Ireland, a small number of changes on the 26th of July, but really at the moment, no news on all restrictions ending. So we're going to be a bit limited on what we can do with talking about guidance and certain aspects of advice where data hasn't matured, but amongst the group, and I'm sure Helen will really do her best to tackle as much as she can at the moment for you. So with that as a segue, Helen, could I let you introduce yourself and share your screen?
Right, let me just share my screen. Right, hopefully everybody can see that. So hi everyone, thanks very much for listening to me today. I hope that what I have to say is of use. I've tried to cover sort of what we know now about COVID since it emerged and in the different leukemia diagnoses, and how emerging from lockdown may change how we need to behave, I think, going forward. So I'm a senior research fellow at the University of Birmingham and an honorary consultant haematologist up the road at QE, as I've actually already mentioned. Oh no. Yeah. So an overview. So I thought we'd cover what we know about COVID so far in patients with leukemia, the vaccination in patients with leukemia. So do COVID vaccines work? A bit about the Delta variant and easing lockdown and what precautions should we take, and what future options are there for immunocompromised patients for COVID. So COVID in patients with leukemia, what we know so far. So I think it is really clear that uncertainty still remains about the natural history of COVID infection in blood cancers across the board. It's assumed that patients are more likely to become symptomatic and require hospitalizations if they contract COVID-19. But there isn't really any reliable data that exists to get the true relative risk compared to age-matched controls. But what I thought I'd do is cover in each of the different leukemia subsets what data is known now. So why the uncertainties? Well, leukemia overall is a heterogeneous makeup of 4 gross different conditions. So chronic myeloid leukemia, acute myeloid leukemia, acute lymphoblastic leukemia, and then chronic lymphocytic leukemia. And then within that, we have all these different stages of disease. We have different therapies and very diverse therapies to tackle each of those different conditions, plus different rates of background comorbidities, depending on the age that these diseases tend to affect people, and then risk factors, which we know influence the outcome of COVID, regardless of whether you've got a blood cancer or not. And then we have to factor into that the infection prevalence and the R value within local areas. And I think probably what we're going to see going forward is very pocketed areas potentially in the UK of prevalence with incidence, with COVID-19, reflective probably of where vaccination uptake has been less prevalent. And I think this is sort of the theme of my talk all the way through, whether we're talking about how we manage COVID, or how we prevent us getting COVID, or even in terms of the vaccine responses. It comes down to individual risk really, and how we can mitigate against that going forward. So I thought we'd first of all talk a bit about what we know now in terms of COVID and acute leukemia, and I've actually put AML and ALL together here because the data by disease type isn't readily available. So talking about both conditions at diagnosis, they generally, if they are an intense, aligned to intense arms of treatment, you will receive an intense course of chemotherapy that's usually inpatient based and is very immunosuppressive. And that induction therapy is difficult really for us to avoid the immunosuppression in that setting. But when we come to maintenance therapy, we know sort of now that what we try and do is aim to keep patients out of hospital as much as we can. We minimize neutropenia, and we tinker a little bit there to try and keep that, to achieve that if we can. And then there are other regimens that are maybe more suitable. So azacitidine plus or minus venetoclax as an outpatient-based setting, the other option for many. And then trial options, obviously, in this COVID era have sadly been reduced to sort of allow for resources to go into caring for the COVID patients coming in. So minimising risk of acquiring COVID-19 through infection prevention strategies is really the of utmost importance and the priority here. And for that, it's really minimising the ward visiting, which we know has had a huge psychological impact on patients. But that really was key to us containing and preventing COVID-19 coming onto the wards. And for that, we also obviously did a lot of lateral flow testing and PCR testing, both of staff and visitors. And I think, on our ward alone, we were doing lateral flow several times a week and PCR testing several times a week to try and make sure we weren't having any asymptomatic carriage onto the ward. And then vaccination now, which I'm going to come on to talk about, is going to be very important going forward. And then the other thing that we've obviously adapted, which I really hope continues actually outside of COVID, is sort of posting out prescriptions where it's convenient for patients and phone clinics where there isn't necessarily a need for patients to come into clinic. But in terms of vaccine responsiveness, I just thought I'd mention here, I haven't actually been able to find any current data on acute leukemias and vaccine responsiveness, but I'm sure that over time some will emerge. So chronic myeloid leukemia. So how common is COVID-19 infection in CML, and does tyrosine kinase inhibitors, do they have any impact? Well, there was a data series from Hubei province for 530 patients that they looked at, and that showed the prevalence there of the COVID-19 infection was around 0.9%. So it was higher than the 0.1% that they saw in healthy, but lower overall than the 10% found within other types of blood cancer. And what they found, interestingly, was that they couldn't see that the outcomes were any worse for patients that had a diagnosis of CML. And they also found that age and the duration of being on a tyrosine kinase inhibitor had no impact either. What they did find was that advanced disease of chronic myeloid leukemia or a poor response to the tyrosine kinase inhibitor did seem to increase the risk of symptomatic COVID-19 infection. But there wasn't any convincing data to suggest that being on a tyrosine kinase inhibitor therapy there isn't any evidence to suggest that it really causes profound immunosuppression or a worse outcome, which is really, I think, quite encouraging. So then we're on to the other chronic leukemia, so chronic lymphocytic leukemia. And here, I suppose there's several elements I think that we can sort of say that we do know a lot more about COVID disease in this cohort of patients now. And first of all, I thought we'd address how common is COVID-19 infection in patients with CLL. Well, the reported prevalence so far is actually similar to the general population. Following natural infection, however, antibodies are detected in 67% compared to 98%. So that's really because, we know that in chronic lymphocytic leukemia, patients do have like a profound immunosuppression, secondary immunosuppression, and associated with that is often the term that we call hypogammaglobulinemia, so where you don't make antibodies particularly effectively. And I think the fact that, this is in a population that we knew had actually had COVID, they're either waning that antibody response, so they're getting an antibody response and they're losing it very quickly, or they're not getting sufficient levels of the antibody detected against the virus in the first place. And so there is that clear discrepancy between the antibody levels following a natural infection in CLL. So does the mortality rate differ for patients with CLL? Well, there's been lots of different studies looking at this. The first came out saying that there was a mortality rate of 30.4% for symptomatic COVID-19 infections. So these are people that had ended up presenting to their doctor hospital with COVID-19 disease. And that was compared to 25% for those who didn't have a diagnosis of CLL. So that suggested it was elevated. Then we went on and there was a study that looked at patients just turning up to clinic. They screened them, and that obviously captured asymptomatic patients as well. And through that, they then found that there was actually a lower mortality, more around 13%, but 63% of that cohort required hospitalization. And then there's the European report, which looked at 151, which was, again, consultants who had patients that were diagnosed with COVID that reported back to that with severe COVID, so hospitalized, and they found the mortality there was around 36%. So depending on what setting you look at, the mortality rates obviously differ. And then this big question came out about, does being on a gluten tyrosine kinase inhibitor have any impact on outcome? And there were smaller reports that suggested that maybe BTKI therapy improves survival of patients infected with COVID-19, but I think it really does remain uncertain, and larger cohorts certainly haven't corroborated those results. But there was a study that suggested that being on a BTKI actually reduced the risk of hospitalization. Anthony Mato et al. Did a big multi-center international study looking at 198 patients. Again, these were patients that I took part in the study, so it was ones that clinicians were actually aware of with symptomatic COVID-19 disease. And in that scenario, they found that the all-cause mortality is around 33%. But survival rates were very similar amongst treatment-naive patients and those on therapy, including the BTKI. I think regardless of which study you look at, age is obviously a very important predictor in the published data in terms of mortality risk. So therapy considerations in CLL, how we've adapted during this time. Well, outpatient-based regimes have been favoured. I guess we're getting to a point now with CLL that we're actually moving naturally away from chemoimmunotherapy regimens anyway, but this I think has probably pushed that through even further at an accelerated rate, really. And for that, we've often adopted the use of the Bruton tyrosine kinase inhibitors, and we were very grateful that AstraZeneca gave access to frontline use of acalabrutinib, and also we could get through the Cancer Drug Fund in a relapse setting prior to NICE approval later on in the year. So that was an option for many patients. And as I already mentioned, we switched to doing home delivery of prescriptions, telephone consults where we could. And then avoidance of chemotherapy, I've already mentioned. And for patients on IVIG, we did a little bit of considering as well, and whether to pause that during the summer months or where available, switch it to subcut regimens so that patients weren't having to attend day units and could stay at home. So moving on to vaccination. So I'm sure you're all really aware that there are two main different vaccine platforms that have been utilised so far in the UK. Obviously, there are more coming through now, but the baseline ones that the vaccine data for blood cancer patients have focused on reflects those that have been administered, obviously, to the UK participants so far. So the Pfizer-BioNTech vaccine was an mRNA-based vaccine, and the Oxford-AstraZeneca vaccine was based on an adenovirus platform, but both importantly delivered genetic information to the host cell to generate the spike protein, which is found on the surface of the COVID-19 virus. So these red things that are sticking out on this little graphic that's at the side there. And the reason that's important is because we know that's very immunogenic, that part of the virus is very immunogenic, but that's also how the virus gets access to our host cells through the ACE2 receptor that lines our epithelium. So that's why the vaccines were targeted against that. And both vaccines that were given, you'll all be aware, required 2 doses to get their efficacy up. But regardless of which you had, both appear to be highly effective in preventing infection in a real world setting. So they're saying 80% plus efficacy in coming out of Public Health England. But I think there's a paucity definitely of trial data in immunocompromised patients with these vaccines. So it's been obviously very important that now real world data really drills down in terms of all the different patient groups that are immunocompromised, but including blood cancer patients. And you probably saw this last week, the surveillance data, so first of all, surveillance data on hospital admissions is ongoing. So that is being collected, not yet out. But the Public Health England data that was released last week identified more than 1.2 million people in the UK that were thought to be clinically in the at-risk groups. And they reported that the immunocompromised group to have vaccine efficacy against symptomatic disease of 74%. And said, well, it's great, it's gone up from 4% after the first dose. And that was regardless of which type of vaccine you got. But I think very importantly, and there's quite a lot of discussion, I think, over the weekend and prior to that, the variability that exists in that immunocompromised group and the numbers makes it very hard, I think, to really conclude from that. And probably because that group includes many different diseases which have a very varied level, I would say, of immunocompromised sort of state, it's very it can be slightly misleading, I think. So Public Health England then went back and revised that statement and said that within these clinical groups there will be people with more severe forms of illness, particularly in the immunosuppressed group, who may not respond as well to vaccines. So I'm going to go on and talk about what we know in the different leukemia subsets now, leukemia conditions, in terms of vaccine data that's coming forward. But I think I've just thought I'd point it out, even at this point, that all patients and household members, and I think the household members is really, really key here, should be vaccinated with the 2 doses and ideally before commencing any therapy. Right, so I thought I'd start with chronic myeloid leukemia. So in terms of COVID-19 vaccination, there is an ongoing study that hasn't yet reported with larger numbers, but the 2 studies to date by Harrington et al., which looked at 16 patients, all of them on tyrosine kinase inhibitor, and after the first dose, so this is only first dose data, and quite impressively, I think 87.5% showed a spike-specific antibody response. And this study was quite nice because it also looked at the cellular responses, which in many of the vaccine studies is still to come. So it's a lot easier for us in the lab to analyze antibody results. It's a relatively quick, straightforward test. So and I think because of that, and because we know that antibodies are very good at what we call neutralizing the virus when it first gets into our body, so they sort of stick to the virus and stop it spreading from in the serum and between cells. Lots of people are focused on looking at the antibody response in health and in disease, but the cellular response can also be really, really important. And I think that's something, because it's a little bit trickier to do in the lab, it's just taken a little bit more time before we've got that data through. But that's not to say it's not coming, and it will be in all of these subset conditions. But encouragingly, with this study in the CML, they found that 93% actually had a detectable T-cell response. Then similarly, Chowdhury et al. Looked at different myeloid disorders, but included a population of chronic myeloid leukemia patients, so 12 of those patients, I think it was, following the first dose. And again, they found a response rate of around 75%, which for first vaccines, very encouraging. But no data yet available on second vaccine response. But as I said, I think it's encouraging in the chronic myeloid leukemia and the tyrosine kinase inhibitor setting. So moving on to CLL and COVID vaccination. So this, I couldn't do this talk and not chat about the study that I've been running here in Birmingham. So we asked through Leukemia Care and the other charities if they could help us to recruit to this study. We were, absolutely thrilled with the amount of patients who got in contact with us and asked to take part. So we ended up consenting 550 patients, really even split, I'd say, of Oxford AstraZeneca and the Pfizer-BioNTech vaccinated population. So I'm hoping that as well will be, really useful data for patients going forward, because I think most of the studies that have come out so far have really focused just on the Pfizer-BioNTech vaccination schedule. And actually, even further than that, most of those have reported just on the standard vaccination, because obviously outside of the UK, most other countries opted to give the 2 Pfizer-BioNTech vaccines 3 weeks apart, which was different based on the JCVI guidance in this country, where we gave them obviously on an extended interval. So what we did, we asked patients who agreed to take part if they would mind doing a home dry blood spot test if they lived outside of the West Midlands, and from that we can elute those little blood spots and we get what we call serology from that. So that's looking at the antibody response, and we can also get total immunoglobulins from that data too. And then for patients that were local to the West Midlands, we asked if they would be willing to donate up to 50 mils in a blood draw, and that was really important, because that blood sample is what we can then go on to look at the cellular responses in, and obviously with the serum that we can also get at the same time, we can do the antibody response, but we can also importantly do neutralization assays, which I mentioned earlier, about looking how well in a in vitro setting, so in the lab setting, how well the virus is able to move. So we use live virus and we see whether the serum from patients that have been vaccinated is good at stopping the virus from spreading from cell to cell. And that data isn't yet available in patients with CLL that I've seen in any studies yet, so it'll be quite useful going forward. And then in terms of, anybody who took part in this study will be aware that we were sort of on the phone for a good 10 minutes asking lots of questions, trying to find out really a bit of background about people's infection history, whether they're on IVIG, whether they've been hospitalized infections, and then a bit about behavior. So whether people have been shielding, going supermarket shopping, and did they know they'd had natural infection with COVID. So just a little bit on what we saw, the results on our first paper that has been published in Blood Cancer Journal or is imminently out, and this sort of showed the difference between the numbers that were going into an extended interval. We did have a few that were taking part in a 3-week interval that all got the Pfizer vaccination, but generally people were on a more extended interval, and obviously it varied depending on local areas what that interval actually was. So what we found after first vaccination is that patients with CLL did have a reduced response rate compared to age-matched controls, so around 34% compared to 94%. And then we found the magnitude of response is also reduced in patients with CLL, and I'll come on to talk a bit about that in a later slide when we talk more about how you interpret antibody responses to vaccination. Those with natural infection, which is these red dots on this right-hand graph, I mean, I was really encouraged by this because these red dots here represent anybody who's had a natural infection with CLL who has subsequently been vaccinated. And you can see that they were very comparable to people who, you know, healthy donor controls who'd also had natural infection. And that was really the first time I've ever been convinced that there are certainly subgroups of patients with CLL who, if they are immune challenged enough, they are able to elicit very good antibody responses. And we found that it boosted 21,000-fold. And that sort of gave me some hope that actually priming for vaccine responses can work in patients with CLL. It's something I've suspected, but I haven't really ever had any evidence to go along with that. And that could be important because with the third vaccine coming in, if it comes in the autumn, then that you know, we may anticipate that we see some decent responses to that subsequent booster vaccination. Interestingly, only 2 out of the 5 were aware that they had been naturally infected with COVID, which I thought, so there's obviously also a decent amount of asymptomatic infection amongst patients with CLL. And I should probably caveat that with the fact that those were patients that we could obviously detect that they'd had natural infections. So there may have potentially been more for that reason that I talked about earlier, where actually detecting an antibody response after natural infection, we know that that is lower in patients with CLL compared to healthy donors. So going on to the second vaccine, this was in a much smaller number at the point that we released this data. So this is looking at 55 patients, and we obviously now have data back on 504 patients, which that data is going to be hopefully coming out fairly soon. But this is looking at the 55, and we were already seeing that actually there was a signal that patients that are taking a Bruton tyrosine kinase inhibitor were having lower response rates and lower titers than patients that were on a watch and wait schedule. Those who had had previous chemoimmunotherapy and were in remission were actually responding very nicely in this first set of data that we saw. And then going forward, we will also have we have a decent number of participants that are on venetoclax, so that will also be included in the follow-up analysis. And that's just a nice infographic that we drew just to show sort of, you can see the vast majority of the little blue figures at the top are on our watch and wait, and you can see most responded. And the patients really on Bruton tyrosine kinase inhibitors and those who were about to start treatment were probably notably as a group the ones who didn't tend to be getting such great responses. The other thing to just mention is those that have got a low immunoglobulin level, which are the green. So there were some amongst the responders who still had a response, but obviously amongst non-responders we were seeing that coming through. And IgA deficiency in particular seemed to be a factor in terms of failing to have a response. Similar data, I would say, by the Israeli group, so Hereshanu et al. They were the first to publish their data set. I think it was on around 130 patients with CLL who all got the Pfizer-BioNTech vaccine 3 weeks apart on a standard interval. And they showed that, again, the reduced response rate and lower titers achieved in patients with CLL, but spike-specific antibody response around 52% compared to 100%. So they were kind of lower than what we had seen. I didn't actually show on our figure, but because it was in small numbers really so far for our second vaccine data, but we were sort of seeing in the order of 78-80% of people, certainly those on watch and wait, that were able to get an antibody response. We're not quite sure what that is, whether it's the vaccine interval or whether it's just the number that we happen to have. So I think going forward on the bigger number that will, you know, the 500 participants, we should be able to drill down on all that a little bit further and understand more about why we could see that difference. They also found that patients who were therapy naive or had had previous chemoimmunotherapy more than 12 months ago were showing the best responses, and again picked out that patients that were on the Bruton tyrosine kinase inhibitor had poor response rate with only 16% responding. So questions related to vaccines that I think remain. I think we really don't know how antibody responses relate to efficacy. So is there a titer that provides protection? And you may have heard people talk about what the immune correlate of protection is, and that's exactly what this is trying to understand. So is there a set antibody level that we know prevents you from getting symptomatic COVID? And I think antibodies are appearing to be a good indicator within the general public and Public Health England data, but that cutoff that gives you protection still isn't fully known. And it remains really difficult as a clinician to advise patients based on laboratory testing how protected they will be from an antibody level. I think it may be encouraging, and probably the thing to take from it is that actually if you do detect an antibody response, I would imagine that that would then going forward mean that hopefully if you did see the virus, you would also be able to mount a response to the virus, but that doesn't necessarily mean that you're not going to become symptomatic in the first place. The other thing that I think is going to be really important, as I've mentioned several times here, is the neutralization assays, which tells us in vitro. I mean, it's the closest we've got, I think, to getting an idea of what would happen in vivo. So if you became infected personally, then that's the closest we've got really to know how well your sera is going to handle the virus. So the other question we don't know is, does an extended interval make any difference to the vaccine responses? So myself and Paul Moss, we've shown that in healthy donors that actually if you get the vaccines on a delayed schedule for the Pfizer-BioNTech vaccine, then we increase the antibody titers by 3.5-fold compared to those who had it on a 3-week standard interval. So that's something also that we're hoping through our study of 500 we may be able to get a signal for. And is there any difference between the type of vaccine, so the mRNA vaccines or the adenovirus vaccine? We looked at this with our first set of data and we couldn't see any difference. And certainly on the CML paper that came out, they also didn't see any difference either. What are the cellular responses like? So this is, I think, going to be really important for patients with leukemia. We don't, as I've mentioned already, I think cellular responses probably aren't so well studied, but they can be really, really important in terms of immunity against viruses, and particularly for patients who have who are immunocompromised from a B cell point of view. So B cells are required and needed, and that's how we make our antibody responses. But T cells are a different type of cellular immunity or adaptive immunity, and they're very different in terms of the way that they see virus and see vaccines even. And just because you're impaired in one arm of the immune system doesn't necessarily mean that you'll be impaired in the other. And certainly work that I've done previously looking at Bruton tyrosine kinase inhibitor patients, actually we do see quite good cellular responses against cytomegalovirus and Epstein-Barr virus. So whether we do in the vaccines, in the COVID vaccines, is something that we're trying to address currently. And then the other thing that I'll come on to talk about in a minute is the combinations of vaccines. So we know in Healthy in the UK that there's a study going on looking at different mix in the vaccines, but also with the third dose of vaccine, what impact does that have on antibody titers? And high titers, you know, in terms of neutralization assays anyway, and the variants, the higher the titer, often the better you can deal with the virus if you within an in vitro setting. And then finally, waning responses. I think that is possibly where a third vaccine could really come in, because we know with any antigen challenge you do get waning of response. So whether you've got natural infection or whether it's through vaccination, antibody titers do drop off and wane over time. And I suppose the thing with certainly certain subgroups of blood cancer patients is if we're starting off at a lower antibody titer to begin with, you haven't got so far to fall perhaps before you become at the level where you know, you are susceptible to the virus. So emerging from lockdown, I mean, I cannot underestimate the anxiety that people are feeling at the moment with the government lifting lockdown completely imminently. And I think for immunocompromised patients across the board, this is going to be of great concern. But I think individual risk will really vary, and that comes down to the type of leukemia, which I think I've probably sort of alluded to, but also management stage, therapy people are on, and underlying biological factors such as whether you have low immunoglobulins, your age, and COVID generally, risk factors for severe COVID as well obviously factor in. So I think really if it is a case you know, where people want to advise, I don't think it's unreasonable really to discuss this with clinicians. And then vaccination of household members should be absolutely encouraged. I mean, that is one thing that it should really be, you know, really help in this scenario, I think. And then be aware of local rates of COVID, because obviously they're going to vary. And that obviously probably is going to reflect the vaccine uptake in local areas. And then managing personal risk as best as possible. So this comes down to personal behaviour, so to risk mitigate against you getting in a scenario where you're going to, readily contract COVID. So avoiding crowded situations, face, hands, protect, obviously wear a mask, and then make sure you're washing your hands plenty. And then I would say notify your haematology team if you test positive, and even potentially if you've come into contact with someone with COVID. And that going forward may, currently we can't, monoclonal antibodies, we're not clear yet, and I'll come on to talk about those in a minute as well, what role they're going to have, but potentially that might be something that becomes available to us. And then the other thing just to say is to make sure you attend for your annual flu vaccination this winter, and also any booster COVID vaccine if and when it's recommended. So the other potential therapeutic strategies, so third vaccine, everybody's heard about the idea of giving the third vaccine this autumn, winter, and the government obviously have announced that third vaccines will be prioritised for the clinical vulnerable. But I guess there's a big question about, will this actually work? And there's likely to be a study opening very, very soon to gauge in the UK how effective third vaccines are going to be in immunocompromised groups. So similar to the COV boost study that's already open, leading from Southampton in healthy people that have been recruited. So a bit on monoclonal antibodies against spike now. So these are engineered monoclonals that recognize that spike protein that I mentioned on the surface of the virus. And the results are already out of one study, the recovery study, which looked at Regeneron's combination. It's actually a combination of two monoclonals, and they used that in hospitalized patients with COVID who hadn't mounted an immune response. And in that cohort, they found that the monoclonals actually reduced the mortality by a fifth. There's also the results of the Provence study, which is the AstraZeneca monoclonal. Again, it's actually two submonoclonals into the infusion, and that's in a prophylactic setting, so a preventative setting amongst patients that are known to be immunocompromised. And the results for that, I'm hoping will be out very, very soon. And there are others coming as well. So I know GSK have got a monoclonal antibody against spike, and I'm sure there are more in the arena. So these antibodies are engineered, and they're generated in such a way that they have a very long half-life. So they're usually given as 1 or 2 infusions or intramuscular injections. And the idea is that they give 6 to 12 months protection, or the antibody should be present for that sort of duration. So I think the way I see potential roles for monoclonal antibodies, if they are commissioned in the UK, which I really hope that they are, is in a prophylaxis session. So patients where we know there's been exposure to COVID-19 and perhaps an immunocompromised patient. Therapy for immunocompromised with confirmed COVID-19 infection, I very much hope that that will be available to us. And then prophylaxis for patients who are unable to mount a response to vaccination or are requiring inpatient chemotherapy. But we shall wait and see what happens in this arena, I think. So I'll leave it there. Thank you very much for listening, and I'm happy to help out with the panel discussion and questions. So I'll stop sharing my screen.
Thank you, Helen. A lot of food for thought, a lot of encouraging information, and it comes down to the difficulty of individuals in being able to measure their understand the level of risk. But it's some really positive information, and the new treatments that are coming for those that are very immune compromised do sound. I just wondered if we could perhaps ask the different members of the panel, just starting off, if the session is about people looking at strategies to manage their own risk, how people in the different communities and as healthcare professionals, Angie as well, what's your guidance at the moment, or your advice as patients and as clinical nurse specialists to help people at this stage? And Helen mentioned one key point was involvement with your care team if you're unclear of your risks. and you want to get some more knowledge on that. But I was just wondering, actually, if we could just be honest, and we can be, you know, use this session to actually make sure that each of us as patients, you know, can, where possible, take the responsibility that we need to be able to act appropriately. So I'm just wondering if the patients on the panel could share how they feel at this moment in time, just to get a fair perspective. There's a lot of input coming in questions, but David, would you be able to share your perspectives at the moment, how you're feeling and how you feel about your patient community, who you're in touch with?
Yeah, so I think there's a few different types of patients, I guess, in CML. So you've got people like me who've been on treatment for 10 years, respond really well. I had COVID over Christmas, and I've had my vaccines, and I've had an antibody test which shows I've got a good response. So I'm personally feeling in a fairly good place. Now, I'm not going to going to busy pubs or anything like that. I'm keeping very safe and sensible as much as I can. I got on public transport for the first time today, but in quiet hours, on a bus, I had 2 other people on it. I wouldn't have got on a full one. But then we've got a bunch of other patients who might be newly diagnosed, and I guess, you know, that's a riskier profile. For those people, would look to be a bit more careful, and I'd consider urging that. But we've also got a load of post-transplant patients as well, who can sometimes get, won't say forgotten about, but we always talk about TKIs for CML patients, but not all patients are in that group. So there's quite a wide variance, I think, of where people's personal risk profiles should be, their kind of clinical risk profile as well. And it makes it important for, I think, the patient to be informed and draw their own personal red lines of what they can and can't do. And of course, some people's jobs, they can work from home, and that takes out a big risk factor from their life. Other people can't. So not everyone can choose everything they want to, I suppose, too.
And from a personal feeling, how with lockdown now lifting, and obviously there being a greater amount of COVID in the community and potentially less protection for those that may need it, how do you feel about things moving forward as a CML patient? Are you feeling very? Are you feeling positive? You know,
on a personal basis, yes. I think I've responded pretty well. And as I said, I won't be jumping into a busy pub or anything. You know, watch the football squarely on my sofa at home last night, rather than out anywhere. But I think you know, I kind of find also when you maybe lift on your own restrictions on what you're willing to do or not go to places yourself, the boundary can often be kind of mental. I hadn't got on a train or bus in over a year and a half, and so I did today. Kind of this webinar kind of prompted me to think, actually, should I try to do something a little bit different that I think intellectually is safe, but I found sort of a bit weird and difficult to do. And actually, the thought of doing it was stranger than the actual act of getting on the bus, which felt like just getting on the bus. But again, I think it is about, you know, patients. You know, are each patient happy with their own situation? How personally nervous might they be? And what's the downside to not doing some of those things? So my kind of view is, if it's, you know, if you're very worried, I think you're much better being safe than sorry. I would prefer to do, my personal mantra would be to kind of go slow in these things. I wouldn't look to make big wholesale change and suddenly go back to my old normal life. It'll be small steps.
Thanks, David. So just to confirm, I know somebody asked in the audience that David's speaking as a CML patient, so chronic myeloid leukemia, not chronic lymphocytic leukemia, as the person who was asking. Julie, you represent quite a small or rare group of acute leukemia patients, but how have you been feeling, and how do you feel right now? And you know, moving into another level of uncertainty.
Yeah, thank you, Nick, for inviting me. Yes, APL is obviously a very, very small community compared to the number of other types of leukemia that, you know, we've been talking about. And And, you know, again, depending on the level of treatment that you've had, and whether you've had any relapses or whether you're sort of through it and you're in remission, and again, the length of time you've been on remission, I can fully appreciate that everybody is all feeling a bit sort of like rabbit in headlights and thinking, well, what am I going to do? How am I going to manage this? I'm personally a great believer in following your gut instinct, and think, you know, don't put yourself in a situation, if you feel uncomfortable about it, don't either go there or take whatever protection you feel you need to do. Personally, I will still be wearing a mask, you know, when I go shopping or if I go on public transport. And again, I will go at times that are less busy. I think even though sort of being in remission for sort of 3.5 years, I certainly would not want to go to any large gathering, you know, like the Wembley or a big concert or anything like that. And even traveling, you know, in your car and dropping off at a service station somewhere, again, I think I would be a little bit, you know, nervous and a bit cautious. But I also feel very strongly that if you've got a great team of clinicians behind you, so when you get your checkups, and if you can somehow understand what your own, you know, level of immunity is, you know, then, you know, in terms of what's your vulnerability to infection, is it, you know, 10 out of 10 or is it 1 out of 10? I think that might be a good barometer for people to use. And obviously your doctors and the people that are caring for you may be able to assist you with that. So I think there's a great sense of personal ownership here, and taking it slowly and steadily. And if you feel that you've come into contact or you feel that you're unwell, then obviously act on it very, very quickly.
Thank you, Julie. Those are interesting insights.
You're welcome.
Sam.
Hi.
I'm looking forward to your story because you always give us some really terrific information and are very candid.
Thank you. I agree wholeheartedly with both points of view. We are able to take responsibility for our own actions. We know how much risk we're at. We know this. I was told 2 different points of view at the beginning. So the medical team at first said, you must behave as if you are post-transplant. And then a couple of weeks later, it was, you're at no more risk or as less risk than a normal person. So I had these very 2 different points of view, and I had to make the decision based on my own opinion. And I know myself, I know how I respond to infections. I know all of this. I have an infection at the moment. So I knew all of that. So I decided very early on that I was going to take responsibility, that this was going to be something that I was going to do for myself. Yes, I was going to listen to what my medical team said, but having had a stem cell transplant, having had acute myeloid leukemia and intensive treatment, knowing that I get infections like a baby every 5 minutes, I pick them up, I was not going to put myself at risk. We had a discussion just before we came online, and I said that I have been out today, and many people are not wearing masks. Now that terrifies me personally. I can see the benefit of them only because I didn't catch, I mean, obviously I wasn't out very much, but when I was out, I didn't catch anything in the last 18 months. And so I can see the benefit of wearing masks. I can see the benefit of not going on public transport when it is busy. I live in a city. I know this city very well. So I can monitor when it's going to be busy. I know that it's going to be really busy. We have an elephant trail coming in the next 2 months. So I know that town is going to be very busy. I know then that I can avoid town at certain times. I know my risks, and I think that that's what we need to remember. As acute patients, we've been managing risks from day dot. It's very different, I know, to chronic patients. Acute patients know their risks, and so they manage them very, very easily. I've always been using hand sanitizer. I have always made sure that I am not in a busy place with people. If people are coughing or sneezing around me, I will leave. I won't be in busy places. I've been doing it now for 5 years. So for me, this is second nature, and I feel empowered to do that. And I also feel empowered to say to people around me who have an opinion as to whether I should be reintegrating myself back into society again, and I'm sure that I'm not the only person on this panel who has that challenge. And I can say my risk is not the same as yours. And I will do what I feel comfortable with. And if I want to leave a busy place, I will. If I go somewhere with you, but I see that I'm not comfortable, I'm not going to be comfortable with that, I'm going to leave. And I'm going to take ownership because it's my health. So I understand that people who don't have these risks will react differently. But for me personally, I am 5 years out. It's not the same as somebody who is in active treatment right now, who will be massively immune oppressed, who won't be able to go out, who will be shielding for the duration. But even at 5 years, because I know I'm double vaccinated, but I've just picked up this horrific virus, and this isn't even COVID. And I've been laid low. I spoke to you earlier in the week, Nick, and I really wasn't very well. I have been laid low with just a normal virus. So I am very, very aware that, you know, COVID will be very different for someone like me, for people like us, for example. But I fought really, really hard to live. And because of that, I still want to live my life, and I will do that. But I will not be taking any risks. I will make sure that I look after myself, but I'm still able to participate in life. It's going to be difficult, but I will do that. I'm terrified, but I'm still going to try.
Thank you, Sam. Some very interesting insights, and I think one that resonated with myself, because obviously we haven't a CLL patient on the panel. I was to be the CLL patient on the panel. Was just reminding myself, going through diagnosis and the stages of CLL, when I started to get more infections, you know, that's when I knew that I was developing infectious issues, and you know, it's very difficult in a community where you've got people that are maybe at much more considerable risks than others. And you know, I have to say myself, as a CLL patient who's IgA deficient, I every 2 weeks infuse subcutaneously with immunoglobulins, and I'm also on a BTK. That my level of fear and my level of trepidation is pretty high, and I'm able to lock myself away, and I'm being probably a bit more restrictive than other people. But that raises that question that's been raised about how do people know? So people need to take responsibility if they can. It's like learning to live with the disease. Is how can you learn as much as you can about what your vulnerabilities are, so that can influence you. So that's what I was going to put to Angela and to Helen. Angela, patients coming to you or on the phone, I know you look after the Leukemia Care Helpline as well. You know, when patients want to understand how vulnerable they are, how do you support patients, and how do you help them focus on that?
So again, as Helen said in her earlier talk, that it would be very much about talking to their clinicians, talking to the team, talking to their nurse specialists. For me, it's always about, of course, you need to balance your risk, but there's also that living your life and the psychological, the emotional side. people do want to spend time with their grandchildren, you know, the bit about quality of life. So there's obviously about the clinical risk, there's obviously about, but quality of life is very, very, very important to us, and probably never more so now that we've all gone through that horrendous time, to sort of almost, if you like, come out the other side, and we need to spend time with families in a safe environment, safe for, you know, the risk for that each person is very, very different, but you know, it is important, I think, as Sam said and David said, you do want to enjoy your life as well. Yes, you might need to isolate, yes, you might need to go on to somewhere shopping at a different time, but it's also about having that enjoyment of life. And I think if people can understand, and we can have perhaps a safer environment when people are coming to hospitals, I think, again, as Helen said, and I think one of the questions that I've read on here are about, will hospitals continue to provide that safe environment? So there may be things that will continue as the same, maybe, you know, face mask wearing for staff and perhaps visitors, and again, as Helen said in a talk, about, you know, a combination of face-to-face appointments, but also, you know, telephone consultations. So it is about, I think, discussing with your clinical teams about where do you fit in, what's the right way forward for you as an individual. So it is trying to balance and treat the person as an individual, but also maintaining that quality of life. I don't know whether Helen agrees with, you know.
Yeah, absolutely. I mean, I echo a lot of what Angela's just said, and I think we're very fortunate often as a clinical team that we've got a lot of information at our fingertips, so we can often look at different blood test results, and that can give us a bit of an idea, such as with the immunoglobulin level. But also, just thinking of what Samantha was saying, I wholeheartedly think that if you are somebody who has a history of recurrent infections, then yes, you are likely to be somebody who's susceptible to picking up viruses and infections, and yes, that should be a warning, I think, to you, and that's something that I really hope the time that we've spent on our study collecting off patients what their history is in terms of serious infections, needing hospitalization. Are you somebody who gets lots of infections? I'm really hoping we'll get some meaningful data from that, because I don't think it's ever really been looked at properly. And then the other thing, yeah, I mean, I'm sure, I'm very, very sure that in a facing situation in hospital, then face masks will still be worn. And then interestingly, the other thing that I picked up on that you were saying, Samantha, is the number of people that I've spoken to this year who get recurrent infections, who have just said, because of the social distancing measures and the face masking, how they just have not suffered from the usual coughs and colds that they usually get over the past 18 months. It's just been, you know, a complete change. So another side that I really hope somehow people still have at the back of their minds, you know, all social distance as much as possible, and wear masks where you can.
Thanks, Helen. Along a similar lines, you talked a lot about antibody tests and other aspects of the immunity, and it just raises a similar question when we've been talking about how people can find out the level of their strength of their immunity. Are there tests? Are there ways that are there tests where patients can test T cell functionality or B cell functionality?
So T cells are tricky, and certainly for patients with CLL, I mean, even if there was a commercially available test, it would be not worth doing it. And partly the reason it's taken us so long to get the cellular results out is because if you think about the blood of patients that have got CLL, they have a lot of B cells in that blood. So, you know, your white cell count goes up a lot with CLL, and actually that is the B cell that we can detect. So what we're looking at with cellular responses is the T cells. So actually, if you send off for a commercial test to look at your T cell results, you're not really going to be looking at T cells, you're going to be looking at B cells. So here, what we're trying to do is we get rid of the B cells and then we home down on the T cells. And that's taken us an awful lot of time, but hopefully that data will come through. So that's the one thing to say. And I'm not even aware of any commercially T cell tests that you can do, but I imagine there probably are companies out there that are doing it. The antibody side of things, I know practice has varied amongst trusts in the UK. So I think some of the London trusts are testing patients, whereas we have adopted the thing or have so far anyway, where we didn't really know how to interpret that result. What do we tell patients if we find out what their antibody level is? So we've erred on the side of caution and have not been doing it as a routine clinical test. But I know many people are aware, because people have emailed me with their antibody results, that there are obviously commercial available tests that you can get to look at whether you've made an antibody response to the vaccination or not. And those vary depending on what company you go through.
That kind of answered one of the main questions as well, which is people have been asking the questions of the value of the lateral flow tests to themselves as patients. Bearing in mind you've explained that there's other aspects with, I mean, from a reliability point of view, are they reliable, and of what value is the information that patients get from their antibody tests, from their lateral flow tests, and are they accurate?
So two different things. So lateral flow testing for detection of the virus, or as an antibody detection? As an antibody
detection, that was the question.
Yeah, so I know that there are one or two companies that are coming out. I don't know, and I wouldn't be able to quote to say what sensitivity differences between that and a serum blood draw antibody test. I don't know that data, but I would imagine that the companies that are selling these tests should have done those kind of validation, and that should be freely available on their websites at the point that you sign up for that test. And something probably to just look into personally, depending on which company you're going to go with. And in terms of the blood draw serological test, so looking at the antibody test through a blood sample, then that again, I suppose, does feed into whether your clinical team is doing that in your local area.
Thank you.
Yeah.
I'm just scanning a couple of questions just before moving on. There have been a few around where you mentioned immunoglobulins and people who are on intravenous immunoglobulin. There's one question where somebody's saying that they're receiving their immunoglobulins as therefore make them safe against COVID. Similarly, a question where somebody hasn't been able to receive that, and now in the current environment, you know, are there plans clinically to change this? I think the person's not been receiving because they haven't been able to visit the hospitals. And looking at the pandemic, have you any thoughts in this area? So one was really just to clarify what's in your what's in your IVIG, and what's not.
Yeah, no problem. So IVIG is pooled antibodies from multiple donors, and will not give you currently protection against COVID-19, because the antibodies against COVID-19 will not have been built up in the community because it's frozen down before you get it. Going forward, that will change. Obviously, as more people become antibody positive against COVID, you'd anticipate that will then pool into the antibody that you get through the immunoglobulin infusion. We're already seeing in the National Blood Service that the amount of blood donations that are coming through that are now antibody positive is increasing, and then there's usually a lag behind for the immunoglobulin therapy, because obviously it's stored and then delivered later on. So that side of things I anticipate will change, and it's something that I'm also looking at, hopefully with the study going forward, if we do subsequent sampling, which I'm hopeful that we can do. And then, what was the other question? I've forgotten now. In terms of delivery of immunoglobulin, I would talk with your local team, because and Angela might know more about this, but there's certainly the option of subcutaneous immunoglobulin, which can often be delivered at home rather than in a day unit setting. So that's something that I would suggest discussing with the team. I mean, it's quite tricky, again, going back to the point that Samantha made, that actually lots of bugs and infections haven't been around as much, so perhaps people haven't needed that immunoglobulin as much as they've needed, but obviously coming out of lockdown now, things will well change.
And just to say as well, sorry, that it depends on the service provision within your locality as well. So some places have got home chemo team, haven't they? So again, depending where you are, it depends what provision you can give to patients in your local area. So it is worth discussing really with your local team when you have those telephone conversations. And so what I advise patients is to write down their questions, so that when they have those telephone conversations with their clinician, then hopefully it's meaningful for both, because then you've spent quite a bit of time on what's you know, what that information that needs to be passed across, and what are the concerns of the patient. So it's I think beneficial for both patient and clinician if you can write your questions down, and then it's hopefully more directed.
And often, just the other thing to say is immunoglobulins therapy is slightly different in most places, in the sense that although the hematologist may think yes we need it, it often has to go through a consultant immunologist in order to get it, and often it's the consultant immunology team that actually run the service. So it's sort of making sure that the message gets passed through, I think, as well, through the clinical teams to the appropriate one who can actually, you know, instigate it.
Thank you very much for clarifying that. Helen, I'm sometimes not very good at multitasking, so I'm not sure in the talk, because I was looking at questions. Did you cover the recent announcement made by PHE on this study?
I did mention it, yeah, and more from a point that I really wanted to sort of bring about caution, because it sounds so optimistic. 74% of people who are immunocompromised have got a vaccine response. That is looking at immunocompromised people overall, and there's such a wide range that come under that in terms of disease subsets, and also different elements of the immune system might be immunocompromised, you know, so I think it's really difficult to.
So it was a little bit potentially dangerous, clamping together a very small portion of immune compromised with the clinically extremely vulnerable as the same group.
Yeah, I think again it goes back to what we've been talking about in terms of individualized risk, really subgroup data that's coming through, so that we can try and really understand what individually sort of your risk profile is in terms of getting COVID and serious disease from COVID, and what your vaccination response rate is likely to be. So
you need to couple that with understanding the infection rate in the community, and
absolutely
every activity you're about to undertake, you're almost having to do a subconscious risk assessment. Would be the way. As a little segue on that, before we move on to other topics, I'm just wondering if patients, if you've got anything that you want to add in terms of strategies that you use, how you carry out your own risk assessment. Are there local tools you use, lessons you learned going through your most immune compromised that you can share that are useful at the moment? Because I've got to be honest, I treat my own life now as if I'm back on chemoimmunotherapy. Then I don't fall foul of anything. And I've actually noticed I've taken on some of those habits with food hygiene, which probably aren't relevant, yeah, but it's just because I reverted, that's what I'm doing. So I'm just wondering, are there other lessons that you can bring as experienced patients to other patients in terms of strategies that you use with regards to your own management?
Do you want to choose someone?
Probably Sam first, because I know how diligent you are.
Thanks. From an acute patient point of view, so from my transplant days or post-transplant days, I was very, very careful about the amount of people that I was around because of the risk of infection, obviously. So I have another level that I have to think about now. I've got to factor this in because 2 of my grandchildren are going to be going to nursery in September. So that changes my risk significantly. And it's managing that risk. It's managing the people. I've found it's managing the people around me more than anything. I know what I'm doing, but it's managing everybody else and saying, you know, we're coming up for winter, going to be having a flu jab, possibly going to be having a booster. September, and I know we've discussed this before, Nick, we've discussed what happens in September. So we get to September and then we know that we have to significantly change our lifestyle until April at least. So I know that I've got 2 months where I can see my family, but come September, I'm going to be going back into some kind of semi-shielding because I know that I'm going to pick up bugs and things like that. So it's me managing those risks and saying, look, okay, I would love to see you. I would love to do this. But I can't because I'm going to keep myself safe. I constantly wash my hands. I constantly sanitize. I still clean the food that comes into my house. I don't socialize anymore. And I've become an even less sociable person than I was before, but I'm okay about that.
So you're happy with the level you set? It's your comfort zone. So that's
yeah,
part of
absolutely.
it. Set it to the level you're comfortable with based on your safe, you know, what makes you feel safe.
I'm mitigating my own risks.
And listening to you there, you're not frightened to make some hard decisions.
No.
Put other people's noses out of joint, perhaps, because they might not understand it.
It's not their health at the end of the day. That's my health. And I'm in charge of that, because, you know, I live on my own. I'm in charge. Who's going to look after me if I get ill? There isn't anyone. So I have to do that. So it's up to me to make those decisions. And yes, they are tough, but I am prepared to do that. And sometimes you have to be strong and say, no, I'm sorry. I'm not doing that. It is going to put people's noses out of joint, but your health comes first.
So just before I move on to others on the panel, your comment about in September starting to semi-shield again. Do you feel you're already semi-shielding? Has COVID, yeah?
I feel like I've been doing it since last March. Okay. I've dipped my toe every now and again in a normal life, and then just thought, oh no, I'm okay, thank you. I feel safer semi-shielding, and I never ever thought I'd say that, but I do. And I feel like that's going to be my norm. Okay,
so with less certainty now, you're feeling safe to make it, you know, stick into a routine where you know you're keeping yourself safe and you're not taking chances. That's really excellent insights. Thank you. Julie, would you mind sharing how you've coped in the past and lessons you've learned that might be helpful?
Yes, thank you. I think when lockdown first started, I felt I was back in my treatment days, you know, and everybody was sort of saying, gosh, you know, I'm watching the birds and seeing everything going on. And I felt like saying, well, welcome to my world, because I've been doing this for the last 3 years, you know, and it's just all a bit too much. I think for me, I probably might be a little bit bolder, if I may, because fortunately my immune system seems to be pretty stable. And there's not been many sort of dips on it. I have to say, I've been lucky I haven't caught anything, you know, any coughs or colds, but then I think the risk of coughs and colds at the moment are probably much less than they've ever been in a very long time. So I will socialise, I will engage, but again, like Sam, I'll be very careful who that group of people is. So I've sort of done a mental scan of those that I would perhaps be comfortable with and those that not so comfortable with. And if I'm not comfortable with it, then I won't go. And again, I will say, I'm sorry, I don't want to upset you, but the reason I'm not coming is because I have to look after my health. Nobody else is going to do it for me. I have to take ownership. I've got to do that responsibility. I did that earlier on this year, and a friend of mine got very upset and she thought she'd upset me. And I said, don't be so daft, you know. I said, I am protecting me. You know, I don't want to get this COVID. So I think I still wash my hands. I still wear a face mask. I will, you know, use my judgment as to where I want to put myself and with whom.
Okay.
We're very lucky that people seem to put where they are all over Facebook. So now we know where people have been.
Yeah.
It's easy to filter those people out.
Yeah. And I think also as people start, I think a bit slightly more worrying, I think, is if people are going to go back to the workplace. So if you've got family and friends that are suddenly going to be commuting, I live not far from the centre of London, so I know that people are going to be going in and out of London. I myself had to do it during lockdown. I had to go into my consultant and I was very, very careful. I did an awful lot of walking around the streets of London rather than getting the tubes and the buses, I can tell you. But so I think, again, I think it's being sensible and doing what you feel is right for you. Nobody can say to you it's not right. And I don't think people should take umbrage on that. But again, it's you managing your relationship with those, hopefully, that will understand that you were in a life-threatening situation. You know, with any acute form of leukemia, which is what I had when I had APL, and I didn't realise the threat to my life until months later. And that sort of has really hit home even more so these last, you know, few months, to be honest.
Thank you, Julia. That's really insightful. I've just maybe just a question, gauging where you are listening to you, because you, with it almost feels a little bit like a setback with the fact now that obviously there's going to be less vigilance in the community, and some of the activities many of us were just able to start, you know, to take part in again, we've maybe had to stop that. What are your thoughts about, you know, shopping, where you might not, others might not be wearing face masks, or in enclosed areas? Are there any going to be any are you going to be changing your behaviour as it is now, or are you?
I think I should certainly become more vigilant. I will, you know, if I go into an area where there are people who are not wearing face masks, I may well not go in there and wait until a time when it's less busy. I'm not going to be going into pubs, or I'm not going to be going back to the gym. I don't feel comfortable in doing things like that. I'd rather be in a space where there's lots of ventilation, you know, and air. So I think, Nick, to say is just judge it according to what the others are doing. And if I'm not comfortable with that, then I won't go, or I'll go at a quieter time.
So it's down to you. And,
yeah.
And some interesting points there. Choosing the time, and you can't necessarily choose your family, but you can choose your friends. Yeah, and yeah. You're going to have to make some, you know, have some firm conversations with family. Yeah, so yeah. It's being selective there. David, you've got some interesting perspectives, because over time you've kind of gauged your own immunity, and maybe you see yourself in a group that's lesser challenged at the moment and have a significant population with you. So how do you go about this? What are the lessons that you've learned in the past that you can bring to bear now that will help?
Yeah. I mean, I kind of would like to see myself as kind of a very sort of facts-driven person. So when we had no facts back in March 2020, I effectively started shielding considerably before there was any such thing as shielding. You know, so in the absence of any info, that I thought that safe then sorry approach was better. Now, as time's gone on, and as we've seen from the presentation today, CML patients seem to do quite well in terms of vaccines, and I know personally I've got information on my own self that, you know, having had COVID and vaccines and producing a good response, that means I'm more comfortable doing some things that somebody else might not be, and for good reason they might not be comfortable doing that. I will still avoid friends who I think are more likely to engage in risky behaviour, or have perhaps just, you know, come back from holiday in a plane somewhere, and still being as sensible as I possibly can. But I do think there are some patients who, again, would be in a very similar situation to me, who have a known good response and are doing very well, who may just be very scared and worried about getting back and doing some normal things, and maybe avoiding going to see friends and things that may enhance their life. So I think it's important not to be over scared, and not to stop doing things for fear. To stop doing things because you've got a good reason to is a very good idea. But, you know, that's kind of why I sort of said to myself, you know, about challenging myself with small little changes in life to see how does that feel. Do I think that is actually sufficiently risky that I shouldn't do it? And so just sort of testing my waters as I go. But it is a difficult one, because if the kind of government's proposed approach sort of plays out and we have 100,000 infections a day, there's going to be a lot of COVID around, right? And I don't fancy getting it again. It was really unpleasant. So I'll continue to be very careful, but within my own envelope of risk. You know, I will go to the gym, because my gym is really well ventilated. It's a small gym, there's only 10 people in a class and it's spread out. I feel that's okay for me. I might not feel that way in a couple of weeks' time. If numbers infection rates go higher and higher, I may then say, actually, that's not okay for me now. So I'll kind of set my own boundaries around what I think is acceptable and what isn't, and try to do it as best I can from kind of sort of facts and knowledge rather than just emotional fear.
Thank you, David. Helen, that raises an interesting question. David's raised the level of infections in the community, and I don't know if it's going to happen, but the talk with regards to the number of healthcare staff who are having to self-isolate and talk about changing the rules there. and the possibility that again the infections will arrive back at your doorstep at the hospitals. Have you got any advice? Because another concern, I will be drawing up the drawbridge. I'm not frightened to say that to everybody. I see myself react to the data, react to what you know about your condition. And my condition is I need to pull up the drawbridge and just be extra vigilant. But one thing that struck me about that, and there's been a few questions about that, is staying well. If maintaining communication with the doctors and strategies to ensure that you don't get unwell at a time when it's probably not a good time to be unwell. I'm just wondering if you've got any thoughts, Angela and Helen, with regards to how people again can just maintain that level of health and also make sure that they're in touch with the healthcare team as they would have been before COVID, because that's an area we've seen a bit less contact, delayed appointments, and now the backlog that people have been trying to catch up on again, it's likely to be interfered again. So just practical. I'm just trying to be practical answering those questions. I don't know if you've got any inputs.
Yeah, I don't know if Angela, because probably the CNS is often a good point of contact.
Yeah.
Sorry, I'm off mute now. So what I would say is usually when patients come to clinic and then they have conversations with the CNS team after, is we have the booklets, we have the advice about keeping yourself well, looking out for any symptoms, contacting us early rather than leaving it a little bit. So the usual things that we would tell them to look out for. So I think it's again reiterating those things to keep an eye out for and contact us early. And if you're concerned, it's fine to pick up the phone and call us. We've been taking, people have been taking quite a lot of calls. But again, is sometimes if you've got friends or family that you can talk to, even if you might not be able to see them, is maybe trying to keep yourself emotionally well. Because I think it's important as well to have contact, because as well, isolation, if you're in isolation and you restricting your activities, then it's going to have an effect physically and emotionally as well, isn't it? So I think it's important to keep in touch with people, but especially your team. We've got information on the leukemia websites as well, so we've usually got quite a lot of information that we can written information and obviously online on the web pages for information as well, and the government guidance. So it's trying to get people to tap into that practical advice. I mean, as well as having that physical contact or the telephone contact with your team. But again, with nurse advisors through Leukemia Care, patients can ring us and we can try and talk through some advice on an individual basis and try and work through some of those questions with them.
That's really helpful, Angie. Helen, did you have anything to add?
Yeah, I completely agree with what Angela said, and I suppose it's just that there is always a way to contact your medical team, whether it be your GP, whether it be your specialist nurse, whether it be through the secretaries, through the consultants themselves. I think generally there is always an avenue that you can take and absolutely get in contact with us ASAP if you think you've had exposure or have got COVID. I think it's far better to tell us in advance than to find out that you've actually needed to come into hospital and pick up patients that way through admissions, because we'd rather know about it earlier rather than later.
Thank you, Helen. I'm mindful now of time and the enormous amount of questions we've got, and we haven't been able to address all of those, so maybe we can field some of those after the event and find a way of getting them back to everybody. It's been very hard to answer so many personalised questions, and I think the message that's come in summary is I myself learned that long word heterogeneity or heterogeneous, that everybody's cancer is different and everybody's level of risk is different and everybody's location is different and everybody's circumstance is different. So what's coming from this webinar, it's down to us as individuals, as patients, to do the work and make sure that you're in contact with your healthcare team for two reasons, several reasons, but one in also aiding with you being able to set the bar that it is appropriate for you, and also just to maintain your day-to-day contact so that your general health's looked after and everything of that nature. I just want to thank everybody for taking the time. It was a fantastic presentation, Helen. There's so much information in there, and you went through it at a rate of knots. So it's going to be available to everybody. So thank you. It's going to be available to everybody as slides, and people can then dissect it at their level and have a read through. There's some really great information in there that I find really uplifting. It's not a bad story. There's so much room for hope in there. The new treatments that are coming through, as somebody who's going to be long-term immune compromised and may benefit from some of the prophylactic targeted monoclonals that are being created, there's hope. And what we need to do is we need to make sure we just set our bar where we feel comfortable and stay safe and let the tidal wave go through. And then, so I'd just like to thank everybody, and then just run through the last slides if I can. I don't know if my colleague has those, if they're able to share. Okay, so just the first slides for those who may not already be aware. Obviously, we've got several information sources. Always a good point to do is point to the website for picking up the news of latest webinars, the newsletters, the quarterly magazine. We've got a great series of podcasts where you can get some real insights from patient engagements and stories and different strategies, and to cope with the condition, also cope with living at the moment. Plenty of activity on social media. We're very busy out there, and you can normally find everything via the website. Next slide, please. Well, there we go. Charlotte at work. Charlotte couldn't be with us today, so she forwards her apologies. But yeah, please join Charlotte's podcast. They really are worth a listen. And the great thing with the podcast is you can be listening whilst you're doing whatever you're doing. And that's what I love about the technology. Next slide, please. Next webinar. 29th of July. Interestingly, we talked about blood products a bit in this webinar because they've been relevant with regards to immunoglobulins. So that next webinar is on use of blood products, and that's on the 20th. So just to understand what blood products are, how they're sourced, and why and how they're used in managing your leukemia, people might find, and it would probably share some interesting information around access and things of that nature. Next slide, please. Support services, probably the most important. We've got a range of support services that are tailored to the individual. So the helpline's always there, as Angela has just pointed out. She's there for you. She's one of our clinical nurse specialist advisors. So please pick up the phone if you feel that you want to reach out. Yeah, there's WhatsApp as well for quick messaging. We've got a network of 30 to 50. I'm never sure of the number, virtual support groups across the country. We also have a welfare advice officer, so that's very relevant at the moment with regards to issues around the impact of COVID on your income, the impact of your diagnosis and treatments on your income, and we also have advocacy support available to you. So we have an advocacy support officer as well. The online forums, Facebook group, we're streaming live to you guys on Facebook. Thank you very much for joining us today. You'll be the first to have the live video. And there is the counselling fund as well that we offer. It's in high demand at the moment, but if you feel that you need a little bit of support with counselling, you can apply to Leukaemia Care, and the counselling fund would normally release funding to allow 6 sessions of you with a counsellor. Next slide, please. As I pointed out there, Leukaemia Care Advocacy Services. So we have, if you want to know latest on COVID, if you're worried about your finances, contact the advocacy team there. The slides will be available for you there, but advocacy@leukemiacare.org.uk will get you to personalised access to one of the advocacy team who can advocate for you. Next slide, please. And the Join Our Life versus Livelihood campaign. That's very relevant to the moment with regards to those that are being pushed into work, potentially could be with changes coming in a vulnerable situation. They're going to have to make conscious decisions that wouldn't be fair. So please do visit us on the website, do visit us on the hashtag address there, and join in with the campaign as we campaign with other blood cancer organisations to actually make sure that blood cancer patients are treated fairly and safely at the moment. Last slide, I believe. And just to end everything with a thank you again to everybody in the audience that's joined us on Zoom, all our friends on Facebook, and our fantastic panel of patients, and Angie, superb clinical nurse specialist, and Helen, who's done so much hard work for you before today to find what data is available in the other leukemias. And it's quite striking how little there is. So we're going to be living with uncertainty for a while, but just stay strong and do the work. Yeah, check on your situation. Don't look at the numbers for the whole group. See if you can find out what your situation, and then live to that. Don't live to others. That's my parting shot. I just want to say thank you to everybody, and thank you for joining us. A terrific discussion. Goodbye. Take care.